Good evening, everyone. Welcome to the BlephEx Dry Eye Decoded Webinar with Dr. James Reinerson, owner and CEO of BlephEx. In existence for only 4 years, BlephEx is being rapidly accepted as the new standard of care for blepharitis and has now been adopted by the Illinois College of Optometry, Mount Sinai Medical College, Southern College of Optometry, and University of California, Irvine, among many others. During this webinar, you will learn all about the latest simple theory of dry eye disease, how to turn dry eye into a brand new revenue source, how to diagnose and easily treat early dry eye, and finally, how to incorporate BlephEx into your practice. Lastly, before I hand it over to Dr. Reinerson, I would kindly request muting your microphone and using the chat box for any questions you have during or after the presentation. There's quite a few of us in here, so we'll attempt to answer as many questions in a timely manner as possible. And with that, I would like to direct everyone's attention to Dr. James Reinerson. The floor is all yours, Doc.
Thank you, Will. Hello, everyone. Dr. Reinerson here, President and CEO of BlephEx. Can everyone hear me okay? Will, can you hear me? Sound check.
Oh, yeah. Sounding good, Doc.
All righty. All right. Well, I appreciate everyone joining us today. We're going to talk about BlephEx. Towards the end of the discussion, the main reason for our webinar today, from an educational standpoint, is to learn about something called DEBS, the Dry Eye Blepharitis Syndrome, which is a brand new way of looking at dry eye disease. And I think this is really going to simplify the understanding and treatment of dry eye from everyone's perspective. We're going to talk about etiology of dry eye disease in terms of biofilm, QUORUM-SENSIng, virulence factors, and inflammation. Then we're going to go into the stages of DEBS, stage 1 through 4. We'll talk about Demodex a little bit. Then we're going to talk about how to treat and prevent dry eye and how technicians out there in the field will be able to come by your offices and certify any technicians to be certified lid hygienists, who will then do some hands-on with that rep, take a little test, and then send in a video of their doing the procedure. So we're going to learn how to understand dry eye without any kind of new research, new studies whatsoever. These concepts have been around for a long time. So it really makes it easy because these are proven concepts. This is existing research. Lid hygiene, for instance, that's well accepted that lid hygiene is important in understanding and treating dry eye disease. The fact that dry eye disease and this lid margin disease is inflammatory base, that's well accepted. Biofilm. Now, this is a new concept when it comes to dry eye disease. But if there's one important concept you take away from this webinar, it's this concept of biofilms. And if you understand biofilms, you'll understand 90% of dry eye disease etiology. And this is probably the other 10%, QUORUM-SENSIng gene activation. We've known about that since 1968. And then Staph aureus virulence factors. The existence or the knowledge of those has been around for decades. So this right here, these 5 things are the essence of dry eye disease, and it's really simple. It's simple if you put these things in the right order. So we put proven facts and proven concepts together in a new way to tell a new story about dry eye disease. To change the way we understand and treat dry eye simply requires a reevaluation of existing evidence. It requires some common sense and some intuitive reasoning, and that's it. Except for one other thing, we have to want to. So we have to be really fed up and tired with this old dogma, the old way of understanding dry eye disease, which was essentially saying we don't understand it. We have to want to embrace a new concept if it makes good, common, intuitive sense to us. If you don't want to do that and you want to stick to the old, tired, multiple etiologies and multifactorial and all that, well, here you go. This is the latest DEBS 2 flow chart they tried to put together with their latest concepts of the way they think they can understand dry eye disease. And this is it. I mean, this is an absolute, it's a mess. I don't know where you start and stop on this. I don't know how this explains dry eye disease, meibomian disease, lacrimal disease. It doesn't. Where in the world do you start and stop? I think there's nothing better out in the literature right now to illustrate the confusion that surrounds dry eye disease than this slide. So they did us a great service saying, look, look how confusing this is. We don't understand it. They have bacteria right down here. One little spot of bacteria and some toxic mediators. The main thing being obstruction here, hyperkeratinization, which does not exist in the first place. So this is just a big confusing mess here. And we can do much better than this. It's really quite simple. So you can continue to believe the poorly understood, multifactorial, different etiologies, overlapping presentations of different diseases. We're going to dispel all of this today and simply rely on the DEBS theory, which is just right here. It's very simple. Bacteria want to survive. They build biofilms that lets them increase their densities. That turns on quorum sensing. Genes are activated, which produce virulence factors, and virulence factors cause inflammation. It's real simple. And then we'll march through how it affects the lid anatomy. Now, in terms of dry eye patients, there's not a shortage of them, are there? I mean, we see these patients every day in our practice. And according to a George Washington University, up to 2/3 of everybody walking in your practices have some form of treatable dry eye or blepharitis disease. And here's how they present. Itchy, scratchy, desert dry, teary, trashy, crusty sty, sticky, burning, makes you cry, you rub and rub and rub your eye. So this is one thing right here that's made this disease so confusing to us as clinicians. Look at all the different ways and different symptoms this disease presents with, making you think it's multiple diseases with multiple presentations. No, it's one disease with multiple presentations, but one simple disease, blepharitis. That's the underlying disease. And it's important to understand what the definition of blepharitis is. So blepharitis does not mean scurf in the lashes. It means simply lid inflammation. But we get out of our programs thinking, oh, if you see the junk, the scurf, we're going to do away with that term today too. But if you see that in the lashes, oh, that's blepharitis. If you don't see it, well, it's got to be something else, right? That's what we're kind of left with, although there's really no one ever really says that to us, but we're left with that understanding. Well, that understanding is wrong. Blepharitis means lid inflammation, nothing more, nothing less. So if inflammation is the end point, it's going to be helpful to know the starting point. So let's get right into why we get inflammatory lid margin disease. And again, we'll get back to this nice, simple, easy flow chart that really explains everything we'll ever need to know about dry eye disease. It's all here on one page. Not a bunch of swirling and circles and overlapping circles and feedback arrows and loops. And what a mess. This is it. This is simple. Bacteria want to survive. They build biofilms. When they build biofilms, that lets them increase their densities. When they increase their densities, they reach something called QUORUM-SENSING, which activates genes. The genes turn on bacterial virulence factors, and that causes inflammatory damage. Then it marches through the lid. We'll get into this part a little bit later. So let's talk about inflammation first, how we get there. Bacteria want to survive. In nature, in order for bacteria to survive, they have to build biofilms. This is like a big bacterial biofilm, a medieval fortress. That can be thought of as a bacterial biofilm. That's what bacteria live in, are these biofilms. And it provides protection against any host that they might be colonizing. And virtually all bacteria produce these biofilms. Here's another way to think about a biofilm. Like a big, huge, multi-level, multi-laminar apartment complex. Now, we all have biofilms. Everybody sitting in on this webinar today has a biofilm on your lid margins, unless you happen to have the only lids on this earth that are completely sterile. And no one has sterile lids, so therefore, if there's bacteria there, there is a biofilm there. It's made of polysaccharide, which is a sugar, and it binds water. Bacteria need water to survive, so they have this fortress with a nice water supply, and it provides substrate for more bacteria and provides protection against the host. Now, I have a 3-year-old son at home. He has a biofilm. Children have this. We have biofilms as soon as the bacteria colonize the lid margin. That happens probably just a few days or a few weeks old. But in my son, his biofilm is so thin and so scant, it's like a single family home when it comes to bacterial colonization. You can't fit too many in there. It's very thin. It can't protect the bacteria. But give that biofilm, or give those bacteria 40 to 50 years to continue day after day, week after week, year after year, continue to build the biofilm thicker and thicker and thicker, and eventually you end up with this big apartment complex that can house billions of bacteria. Now, biofilms grow virtually everywhere, according to Montana State University, in almost any environment where all you need are three things: moisture, nutrients, and a surface. And if you have those three things, you'll get a biofilm. They're at the bottom of the ocean around deep sea vents. They're on glaciers in Antarctica. They are literally everywhere that you have these three things. So to think that they're not on the lid would be ludicrous. Of course they're on the lid margin. There's bacteria there, there's a surface, there's nutrients, there's moisture, there's also warmth. So of course we get biofilms on the lid margin as well. Watnick and Coulter call them city of microbes. A biofilm is like a city. And they comment that the biofilm is the prevailing microbial lifestyle. So what's the alternative? Well, a bacteria can be planktonic. That means individual, free-floating in nature. But in nature, they don't last very long that way. Something's going to come along and gobble them up. So in nature, they have to live in a biofilm to survive. The only place we really encounter planktonic bacteria is in the test tube in a laboratory before they've had a chance to build a biofilm. So in nature, they live in biofilms. If you've ever had dogs outside and you have a bucket of water you change every few days, and you've ever washed it out and you feel that little slime on the inside, that's a biofilm. If you've ever been wading barefoot in a creek and slipped on a rock, you slipped on a biofilm. So they're absolutely everywhere in nature. This is how bacteria live. This is the prevailing lifestyle. Here's a planktonic bacteria, individual free floating. I just can't go with the flow anymore, Doc. I've been thinking about joining a biofilm. Well, he better join a biofilm or he won't be around very long. Now, we've known about biofilms since 1684, and this is a really gross example, obviously, but this is plaque on a person's teeth, an extreme example, just to drive the point home. Since 1684, when Anthony van Leeuwenhoek scraped a man's teeth, and he commented, the number of these animalcules in the scurf of a man's teeth. Now, here's an interesting word, scurf. Used by dentistry back in 1684, but they don't use that term anymore. What's the medical definition of scurf? Anybody have a medical definition of the word scurf? No. It just means something that we don't know what it is, and it's probably not supposed to be there. It looks like debris, nasty crud, pick your adjective, but there's no medical definition that doesn't mean anything. It's a catch-all term. Scurf, debris is not supposed to be there. We can do better than that in eye medicine now because we know what this stuff is. Scurf is a nondescript term. Biofilm is what we've been looking at. Biofilm, that describes what we see on the lid margin, and it's implicated in all these diseases. So biofilm is not new to medicine. And this disease list here is growing every few months to years. It's growing with more diseases having biofilms implicated as being a complicating factor. Now here's the only study we're going to talk about tonight. This came out in 2016. Great study. 55 eyes underwent a surgical prep before surgery, uncomplicated cataract surgery, but before the patient was rolled out of the operating room, they cultured the lids and the fornices and the conjunctiva, looking for what bacteria were there during the entire cataract procedure, what had survived the prep. 16 eyes were culture positive with 34 different bugs. And here's the amazing thing, 32 out of 34 of the bacteria cultured from these lids after cataract surgery were biofilm formers. So that should take any question right off the table. The bacteria that colonize our lids form biofilms. And now it should be no question why we still get endophthalmitis on occasion. Because all it takes is 10,000 bacteria on a little microscopic speck of biofilm you probably can't even see, that sticks to an instrument, sticks to the lens, or somehow gets in the eye, and then you've got a surgeon's worst day, and you've got a patient's worst day as well. So it's not a mystery. We know it's well documented that endophthalmitis, the bacteria come from the patient's own lid flora, and now we know why they're there, why they survive, and how they get in. They got in on a little piece of biofilm. Here's a biofilm in an industrial pipe. How about a pacifier? Yep, there's a biofilm in a pacifier. A surface, moisture and nutrients, you're going to get a biofilm. They're everywhere. Everyone's sink strainer has a biofilm. You can't see them because you don't have a $100,000 confocal scanning microscope sitting in your kitchen. But if you do, you can see the thriving biofilm on your sink strainer as well. And lo and behold, biofilm on the lid margin. This is biofilm. This is biofilm wrapped around the eyelash that formed around that eyelash when the eyelash was down inside its follicle. Wrapped around a nice thick biofilm, then the lash grows, out it comes, and you can see it. This is not keratinization. You don't get this big long layer of keratinization on the lid margin. The back half to 1/3 to 1/2 of the lid margin is non-keratinized stratified squamous epithelium anyway. There's no reason for keratin to be back there. But at some point in the lecture, someone said, oh, it's keratinization around the meibomian gland orifices, and it kind of stuck because we didn't know what it was. And it made sense. People went with the keratin idea, but there's no keratin back there. This is biofilm. Keratin cannot come up and wrap itself around an eyelash. And this stuff is obviously sticky, molds around keratin. The lash is keratin, but this isn't keratin. Here's keratin down here, skin, but these chunks of sticky stuff isn't keratin. This is biofilm. And this is what BlephEx removes. And you simply must have a BlephEx in your practice if you're going to remove your patient's biofilms. Now the biofilm forms here first on the lid margin and very easily gains access to the lash follicle, because there's a space right here alongside the lash, so it can pretty easily access this area and begin forming around the lash down here. Then it grows out, and you can see what's wrapped around it. Now I said this biofilm is impenetrable like a fortress. Literally nothing can penetrate it. A surgical scrub, we've already seen a study that shows a surgical scrub can't penetrate it. Antibiotic drops can't penetrate it. Our own white cells can't penetrate these biofilms. So do we honestly think that a drop like Restasis or Latisse can possibly penetrate this biofilm? So next time you use Restasis or Latisse and you wonder why you got a suboptimal result, now you know. You were using these drops on a patient who had a nice, thick, protective biofilm. The drop never saw human tissue. So of course, they don't work sometimes because the biofilm blocks them from gaining access to areas where they might otherwise have an effect. Now the biofilm is a polysaccharide, that's a sugar. No better food source in nature than a sugar. So now we know why Demodex is up there hanging out, living in the lashes. He's going where the good stuff is. He's going where the dessert is. So he comes out at night and he grazes away, eating this polysaccharide biofilm. Now this is an artist representation. Obviously he's not this big. They're pretty small. But he's coming out at night eating biofilm because it's a fantastic food source for this scavenger. Now this is a very busy slide, and I only put it on here for this title right here. Microbial biofilms sticking together for success, because that's what they do. The biofilm allows them to do that. It makes them all more successful. And the other parts of this slide that are important is how biofilms migrate. They do it by detachment, dispersal, rolling, and rippling, because they're constantly trying to find other areas to conquer, other areas on which to form a biofilm. So remember this as we go forward, especially this detaching. It may be important in understanding further aspects of biofilm dry eye disease. Now these biofilms build up on our lid margins our entire life because it's the only place on our whole body. Now think about this, one spot on our entire body that never gets washed our whole life. Our whole life. We never ever washed our lid margins. Everything else gets washed, but not our lid margins. And this is an area that's warm and it's moist, it's got bacteria colonizing it. No wonder the biofilm builds up, and then the bacteria build up. More biofilm, more bacteria, and you get this vicious cycle started. Now, once you get increased densities in this thickening biofilm, you get increased virulence. The bacteria become virulent. Well, why would that be? It's the same bacteria, right? Why do they suddenly become more pathogenic? Very interesting question. That's where QUORUM-SENSING gene activation comes in. We've known about that since 1968. QUORUM-SENSING gene activation, discovered at Harvard by Dr. John Woody Hastings, and he discovered that bacterial populations as a whole, as a group, can sense when they reach a certain quorum, a certain density, a certain population number. And when they reach that quorum, genes that were lying there dormant before, they suddenly activate and begin producing these toxins, exotoxins, certain enzymes, superantigens, horribly inflammatory superantigens, responsible for toxic shock syndrome. Now, all these things are being pumped out onto the lid margin as soon as you reach quorum sensing, which is going to happen in our 40s or 50s when we have a thick enough biofilm. You see, that's why you get inflammatory disease later on in life, not as a 3-year-old, but typically later in life, with some exceptions. So now we wonder why your meibomian glands eventually get inflamed and atrophy. Well, your meibomians are now living in a Springfield toxic waste dump, and they're never allowed to step 1 foot outside that toxic waste dump, ever. Constantly exposed to these toxins being produced every second of every day, whether you're awake or you're asleep. So no wonder the meibomian glands eventually get inflamed and shut down. Now, I mentioned superantigens. In order to understand superantigens, you got to understand antigens. Here's an antigen, an environmental antigen, exposed to a antigen presenting cell that has this exact surface protein receptor here that matches the shape of the antigen. So it activates the antigen presenting cell, who then goes around, finds a T lymphocyte with the same surface protein shape, and sticks that little antigen in there and activates the T lymphocyte. And you get a very limited inflammatory response. That's a typical inflammatory response. Superantigens, which are being produced on the lid margin now, don't work that way. They don't care about this little shape here. They simply say, I'm going to grab you and I'm going to grab you. I'm going to put you together and I'm going to activate every T cell I come across. So not worrying about that little shape in there, it just grabs these parts of these cells and puts them together and activates. Excessive immune response results from all these activations of T lymphocytes. Huge immune responses. So in the case of toxic shocks, in the case of toxic shock, you get a Staph aureus colony living in a biofilm, producing superantigens, gets into the bloodstream, and you get enough of them, and you get enough inflammatory response, you get vascular collapse and death. So the point here is that these superantigens aren't fooling around. They cause massive inflammatory responses. So yes, it should be no question that we get inflammatory lid margin disease with not just superantigens, but other toxins as well. Now here's another way to think about quorum sensing. Here's the guys here, the characters of the symptoms. It's the same characters here, but something's a little different down here. We have a lot more of them. We've multiplied them times 1,000. So now they've achieved quorum sensing, and now they have virulence factors. They have torches. Now they're ready to go burn something down. Same people, just more of them, and now they've got something to go do some destruction with. That's what quorum sensing is. Now, how do they achieve quorum sensing? Well, they do it using a molecule called homoserine lactones. They secrete these HSLs into their environment in a test tube where they're planktonic. There's never a high enough concentration for these things to be able to communicate with one another. But you put them in a biofilm where they're relatively immobile, the HSLs can concentrate, and now suddenly they can communicate. They know what their population levels are by sensing these HSLs concentrations. And they can communicate cell to cell, the bacteria, and across species. So Staph epi can talk to Staph aureus can talk to Pseudomonas. They all communicate together, and they all let each other know when they've reached quorum sensing. It's really quite remarkable, the survival skills that bacteria have come up with by living in biofilms. Now, Staph epi is the primary biofilm former. Produces a moderate cytolytic toxin, but his main role is producing biofilm. There's a picture of a Staph epi biofilm. Staph aureus, on the other hand, he also produces biofilm, but his main contribution to inflammatory lid margin disease is the virulence factors he's producing. And look at these virulence factors. We mentioned some exotoxins like toxic shock syndrome. He also causes food poisoning, scalded skin syndrome, a horrible inflammatory disease. And then there's all these enzymes, nucleases, proteases, lipases. All these enzymes are being produced on the lid margin, breaking down our lipids and anything else they come into contact with. And then cytolytic toxins, alpha hemolysins, beta hemolysins, all in an effort to try to produce more of a food source by attacking host tissue. But these this burgeoning bacterial population needs more food source, so they start producing these virulence factors. And here's an important one right here. Now this is spelled correctly, adhesin, not adhesions, adhesin molecules. They're like bacterial superglue. So when the bacteria find a nice environment, a surface with moisture, nutrients, especially warmth, they want to stay there, right? So the way they do that is they produce a bacterial superglue that secures that biofilm in position so it cannot be easily dislodged into the environment. I told you, these bacteria are amazingly clever at how they survive. So it's no wonder that this decades-old recommendation of doing home scrubs has been a failure. We're asking patients to go home and essentially try to scrub off superglue from their eyelid margin. It's not going to happen. If you've ever had a patient with superglue in their lids, and I have, you know, you can't get it off. It just has to wear off. So home scrubs, next time you recommend them, think, I'm recommending my patients to go home and remove biofilm. It's not going to work. That's why lid scrubs at home have been a failure and very frustrating for patients. Now here's a picture of a Staph aureus biofilm. And I told you earlier, they're impenetrable to our own white cells. And look at this, these are our white cells. They cannot get in this bacterial biofilm. Absolutely impenetrable. So no wonder they survive. These bacteria survive beautifully on our lid margins. There's nothing there to disrupt their biofilm. That's what we have to start doing in our offices with our with our BlephEx devices. We have to start disrupting biofilms because nothing else is going to do it. Deng Xiaoping, who is he and what does he have to do with dry eye disease? Well, he was the communist Chinese leader back in the 80s, and his favorite saying was, hide your strength and bide your time. Well, I tell you, I think he got that saying from bacteria because that's exactly what they're doing. You might think, well, why do bacteria go to all this trouble to go through quorum sensing? Why don't they just start producing their virulence factors and liberate more of a food source from the very beginning? Well, the answer, again, it's clever. They know if they start causing inflammation too soon, they do not have a nice, thick, mature enough biofilm to withstand the host response. And so the host response will come in and wipe them out. So bacteria are clever. They're like Deng Xiaoping. They're hiding their strength. They're building their biofilm. And my son, they're building biofilm, not causing any problems, no pathology. They look up at the host, they say, hey, nothing to see here, move along. We're just building a biofilm. We're not causing any problems. We're not causing any inflammation. Nobody come in and bother us. And so they do that for 30, 40, 50 years until they know they're in a thick enough biofilm via quorum sensing, and then they start producing virulence factors. You see? That's why inflammatory lid margin disease typically occurs later on in life. Now, it's the virulence factors are the real villains. If bacteria didn't produce virulence factors, they wouldn't really be a problem. But it's what they produce. And these virulence factors are produced wherever the biofilm accumulates, on the lid margin, within the lash follicle, and eventually within the meibomian gland. And you get chronic inflammation from the inside out. So now we've just started off with bacterial survival and realized why we get inflammatory damage, and it's so simple. Not a bunch of swirlies and feedbacks and we don't know and overlapping presentations. It's not all that. It's so simple. It's not multiple etiologies. It's one etiology. Bacteria want to survive. That's it. Now, there's other factors that can make it better or worse, but there's one etiology. Bacteria surviving using a biofilm, and that's the key word to remember. And that's what leads to inflammation. So now we're going to march down this path and see how that inflammation affects the lid margin. Now, again, it's important to remember that blepharitis means lid inflammation. Don't ascribe to it anything more or less than that, just lid inflammation. And let's get rid of some confusing terminology while we're at it, because this has also been mentioned out there in the lecture circuits, and everyone sort of adopted these definitions without really thinking too much about them. But if you really give it some thought, you realize that anterior blepharitis, it's a false distinction. It's used to define biofilm within the lashes. Well, what's inflamed there? The saying anterior blepharitis, does it describe a certain state of inflammation within the eyelid? Can an eyelash that has a chunk of biofilm on it be inflamed? No. Eyelashes are inert keratin. They can't be inflamed. So this is not a separate disease. You see this with all types of stages of lid disease. You get it along with MGD. So now what are you going to call it? Anterior, posterior blepharitis? And speaking of posterior blepharitis, another false distinction, not a separate disease. And it's also called MGD, meibomian gland disease, also called evaporative dry eye disease. So which is it? Is it blepharitis or is it dry eye? Can we just make up our mind? And now you can also have aqueous insufficiency along with that. Is it still posterior? Maybe now we should call it panblepharitis, since there's anterior and posterior and lacrimal involvement. It gets kind of silly trying to describe one disease based on where we see pathology and not realizing this disease didn't start off in the lacrimals. It started off in the follicles and just marched its way through. Here's a good one, staph blepharitis. Okay, as opposed to what? What blepharitis doesn't involve staph? All these false distinctions still involve staph, so where does this come from? How is this different than anything up here? It's not. All blepharitis involves staph. And seborrheic blepharitis, this is a real kicker. I was already out of my residency when I first heard that term, and I thought, well, I didn't learn that in residency, so I better research what that is. I thought, well, it must be like seborrheic dermatitis, so I'll go study seborrheic dermatitis, and I'll understand seborrheic blepharitis. Well, seborrheic dermatitis, areas of skin rich in sebaceous glands that become inflamed, and you get this raised maculopapular rashes. But wait a minute, this occurs more in younger patients. Thinking that doesn't sound like my patients I'm seeing. I don't see these raised rashes on the eyelid margin. These maculopapular rashes that come and go, they wax and wane in younger patients. No, I'm not seeing that on my patients' lid margins. You get this sort of waxy secretions. Thinking that it doesn't make sense to me, and I never really fully adopted that term. And none of us should. Now, I'll grant you, you can get seborrheic dermatitis of the skin of the eyelid, just like anywhere else. Seborrheic dermatitis. That's not a lid margin blepharitis disease, so we should reserve the term seborrheic dermatitis of the lids for that disease that does respond nicely to steroids, but we should not use that term in trying to describe any state of disease that has to do with inflammatory lid margin disease. We need to make medicine simple, not make it more complicated, which is what we've done with this disease for decades. That lets us be better doctors. We should get rid of that confusing and inaccurate terminology and really just make it so simple. DEBS. It's an acronym for dry eye blepharitis syndrome because this is all one disease. And I'll prove that to you through the remainder of this lecture. Dry eye disease is just a late manifestation of blepharitis, but the underlying syndrome is inflammatory lid margin disease that leads to all this. Dry eye blepharitis syndrome presents in different ways, affects different parts of the lid, one disease. Here's the stages of DEBS. Stage 1, folliculitis. Stage 2, meibomitis. Stage 3 is lacrimalitis, to coin a new term. Stage 4 is actually a breakdown in the lid itself. Now, we've talked about biofilm already. Does anyone still think that this is dandruff within the lashes? You hear these people say lash dandruff. Come on, can't we please do better than that? We see these little collarettes around the lash, and we still let people talk us into believing it's somehow lash dandruff, like what we get on our scalp. This is biofilm. Where did this biofilm used to be? Did it just fall down from somewhere and form a little ring around that lash, a little collar around that lash? No one would possibly believe that if you really think about it. Here's a collarette right here just getting ready to form. It's pulling off the lid margin. A chunk of biofilm pulling off the lid margin. This biofilm extends from the lash line all the way back here. It's right here as well. You just can't see it very well. Number one, we're a little bit out of focus. And number two, the main reason is the biofilm's translucent. You see, it's translucent. When it's tightly adherent to a surface with no air under it, you see right through the biofilm and you see the tissue underneath, not realizing you're looking through a translucent biofilm. But it's all through here, and I'll show you pictures of that. This was getting ready to pull off. These pulled off maybe a week ago. It was down here. A chunk pulled off as the lash grew, maybe 3 weeks, maybe 4 weeks ago. So they pull off and they just ride on that eyelash as the eyelash grows out. easy to understand what we're seeing now once you understand biofilm. Now here's the mattering, clumping, we call it. It's biofilm. That sticky polysaccharide almost looks like that picture I showed earlier with the bacteria stuck in it. Now this is early stage folliculitis. You see a little swelling right here around the base of the eyelash. Now, if you will go back to your clinics and start looking at the base of your patient's lashes, you're going to see volcano sign, especially in your contact lens patients. I would be willing to bet that 95% of your contact lens wearers have these little volcano signs. They already have an inflammatory biofilm within the lash follicle causing edema. You'll see this, or you'll see accumulation of biofilm on the base of the lash. See that clumpy stuff there? Biofilm here, obviously. Now let's look at the rest of the lash margin. This shiny, crinkly appearance, that's biofilm. We were never taught to look for it, but that's what this sort of granular, shiny, crinkly appearance is. It's all biofilm. We know it's got to be there. Bacteria colonize the lid margin, so it shouldn't be a mystery at this point. This is a great slide because the focus is perfect to show this biofilm, shiny, crinkly, all the way back here. Biofilm, you can see it all here well, out of focus there, but you can certainly see it here and see how you could actually look right through it. Follow it up, follow it up, follow it up, and boom, right here, that's going to be a collarette. That's just starting to lift up. And as soon as you get the slightest bit of air under the biofilm, it becomes opaque. Now you can see it. So you see it's been right in front of us the whole time. We just never were taught to appreciate it. This is going to be a collarette right there. That's going to be a collarette right there. It's all biofilm. But it's not just there and there. You see, it's everywhere here. Volcano sign there is edema around the lash. Here's distichiasis, so glands of mole have converted to lash follicles from chronic inflammation here. This is fairly severe folliculitis. See this, the line of inflammation here, adjacent to where the base of the lash bulbs is? And if it goes on long enough, and it's severe enough, eventually you start losing your lashes. Because the lash follicle gets so damaged that you not only get misdirected lashes from follicular damage, but you actually get lash loss. Another chunk of biofilm here pulled off. Obviously not lash dandruff, so we get rid of that term. There's no dandruff on the eyelid margins. Now, folliculitis is always going to be stage 1, and we kind of touched on it earlier. Why is it always going to be stage 1? Well, the biofilm forms right here, and it has easy access to the lashes. Right then, there's a space here. So all it has to do is make its way down here and then keep accumulating and get thick enough to when it eventually starts causing inflammatory damage. Folliculitis stage 1 DEBS. Now let's talk about stage 2, meibomian involvement. Here's some healthy oils, but when they start getting broken down from lipases, you get that frothy, that sudsy appearance. Patients will complain of burning. And then if it continues, you don't get anything at all. No secretions at all. Now you have obstructive meibomian gland orifices. This is called non-obvious MGD, just because there's no flagrant, obvious inflammatory disease back here. You can see some little elements of these telangiectatic vessels showing some low-grade inflammation. But primarily, it's just obstructive meibomian gland diseases. Now, if I'm calling MGD stage 2 DEBS, that means stage 1 must still be present. It didn't go away, right? It doesn't go from one to the next to the next. It accumulates. It goes 2 on top of 1, and then later 3 on top of 2. So is there folliculitis here? Sure. Look at the base of the lashes. Start looking at your patients. You're going to see tons of this. There's an inflammatory biofilm at work here, causing inflammation of the lash follicle because it's gotten thick enough, but not yet to the point where it's causing a lot of inflammation in the meibomian glands, but it is plugging it up. You see, every meibomian orifice has this little creamy column of biofilm stopping it up. But we can do better than that term biofilm here if our emphasis is to be accurate with this disease, because what is this really? Is it just purely biofilm plugging up the meibomian gland? No. It's sludge-like meibomian products. They get altered and get mixed with biofilm. So now it's meibum mixed with biofilm. So how about we call this meibofilm? Meibofilm is what accumulates in the meibomian gland. It's more accurate. It's biofilm mixed with meibum, and it blocks the ductules. So now think about these little columns here as we go to the next couple of slides. Right now, it's just plugging up. Now, if it continues and that meibofilm keeps accumulating in the meibomian gland, where is it going to go? Well, you'd think, oh, it's going to eventually just kind of squeeze out here like toothpaste, right? Yeah, it doesn't really do that. You get little domes here of microfilm. Now, this is where people said, oh, you get keratinization around the lid margin, right? Keratinization around the lid margin, around the meibomian orifice. No, you don't get keratinization around the meibomian orifice. This is a dome of biofilm. Here's keratin up here. This is a dome of biofilm. Why do you get a dome of biofilm? Why doesn't it just come out like toothpaste? You can see it's under pressure, bulging up here. Something's trapping it. What do you think is trapping these columns of microfilm trying to get out? Well, let's say this is a 40-year-old, 50-year-old patient. What do you think's blocking the microfilm from getting out? A 40 to 50-year-old biofilm, the original biofilm, the biofilm my son has. It didn't go away. It's covering the entire lid margin. But now in this patient, you have accumulating so much in the meibomian glands, obviously causing inflammation. Look at the horrible inflammation back here. But it runs up into the original biofilm and it's got nowhere to go. So imagine taking a toothpaste tube, that's a meibomian gland, and covering the opening with a little saran wrap, that's the biofilm. And then squeezing gently. What's going to happen? You're going to get a little bulge up under the saran wrap, but it can't really go anywhere if you seal it off nicely. That's exactly what's happening here. It's not a mystery. We don't have to try to create these sort of strange, mystical fantasies of keratin somehow migrating down here and sitting on top of meibomian gland orifices. No, this is obviously not keratin. Even just looking at it, it doesn't look like keratin. Domes of microfilm with nowhere to go. These are the same thing right here. These just aren't as advanced. They're not up bulging out yet. So doesn't that make perfect sense if you understand biofilm? It explains everything we see. Now here's a lid where, again, this is obviously not keratin. Here's keratin up here. These are domes of biofilm trying to get out. Here's one that auto-expressed. See, it popped through the original biofilm somehow, and you got the little tube of toothpaste squirting out. Does keratin do that? Does keratin come from a meibomian gland? Can we squeeze keratin out of a meibomian gland? Obviously not. So let's dispel this notion of any kind of keratin being back here causing pathology. It's not keratin. And if you do any manual expressions in your office, you witness that right at the slit lamp. You witness that. You see it with your own eyes. You see those little domes that are supposed to be little keratin domes, and then you squeeze, and it just rises up on a little column coming out from the meibomian gland. So we're supposed to think that we have a brand new substance here, keratin, on top of a brand new substance down here by a microfilm. No, it's all contiguous. It's one structure. It's a column of microfilm. Now we're squeezing it out of the meibomian orifices, and everything now falls together and makes perfect sense for us. Now in this slide, you can really appreciate why meibomian gland disease, meibomitis, is always going to be stage 2. Look at the size of the follicle here. It's relatively small with an easy access. I showed you on some of the earlier slides. Compare that to the size of the meibomian gland. It's absolutely huge. Huge. It takes longer to affect a larger structure. It just takes longer for it to accumulate in here and get thick enough to cause virulence. But it will eventually start causing inflammation, and then it gets so packed that the microfilm here's got nowhere to go, and it starts bulging out right here. Easy to understand in this cross section. And if it goes on long enough, what happens? Well, we get meibomian gland dropout and atrophy. We can't let our patients get to that stage. We cannot. Incidentally, here's an interesting thought. You know, it only takes maybe 5, 6, 7, 8 meibomian glands to really have a normal lipid layer. But you know, we've got what, 20 to 30 to 40 in each lid? It's a variable number, but we've got all kinds of extra meibomian glands. That's interesting. Why do you think that is? Think about it from an evolutionary standpoint. Did our ancestors living in caves have access to a BlephEx? No, they didn't. So over the course of evolution, we evolved to develop multiple extra sets of meibomian glands, even though we didn't need them, because in an evolutionary standpoint, back then when we lived in caves, they got Blepharitis as well. and they ended up getting dry eye disease and couldn't see as well. So there was evolutionary pressure to have more meibomian gland disease because it was normal for them to become full of biofilm and drop out from atrophy. That was normal, the normal progression. So we had 40 instead of just the 6 or 7 or 8 we needed. Explains everything. Now let's get into the lacrimal gland involvement. I'm not talking about the big lacrimal gland that secretes when we cut onions or we cry. We're talking about the accessory lacrimal glands. Now, as we go along here, if we have any questions, just open up your little chat box and we'll try to get to them at the very end. But wait till the end before you submit your questions, because if you start submitting them early, then I've got to go back through and I've got to try to scroll up and find the questions, and it keeps trying to drop back down. So it's very difficult. So just wait till the end, submit your questions in the chat box, and we'll try to get to them. I'm sorry, someone said lost sound. Thank you for that. I somehow muted. Okay, I'll back up on the slide. So here's our accessory lacrimal glands, responsible for the regular maintenance aqueous secretion, constantly secreting to keep the eyes wet with aqueous. Looking at this section here, we can appreciate all 3 stages. Stage 1, folliculitis, small, easy access. Stage 2, meibomitis, larger, difficult access. Stage 3, lacrimalitis, because the lacrimal glands here are relatively secluded from where the biofilm is being produced. They're protected way back up here behind enemy lines. So they stay protected. But if we have little bits of biofilm, remember the dispersal, rolling, rippling, how biofilms migrate? Well, if they're dispersing little bits of biofilm, maybe 100 times a day, for 70 to 80 years, do you think it's conceivable that a little bit might eventually get a toehold? And once it gets in a toehold, it gets a toehold in a gland that has a surface and moisture and nutrients, that biofilm will thrive and develop there. So that's one way we could be getting biofilm in our lacrimal glands. We don't know for sure. The other way is, okay, we get just a very slow crawl of an attenuated biofilm that's very slow because of constant lid blinking and constant tears, constant eyeball movement, but very slowly makes its way up here and accesses them directly with a very thin attenuated biofilm. It's one of the two. Don't really have a preference on how it gets there, but we're pretty sure it gets there. Now here's a stage 3, no lacrimal. Got folliculitis, got swelling here, no meibomian product, and no lacrimal secretion here, minimal tear lake, stage 3. Here's a great slide. You can tell a lot from this slide. Stage 3, so we know this has been going on for probably 60, 70, 80 years. The lacrimals are involved. They're not putting out any aqueous. Look at this. It's just dry back here. No meibomian puddles at all. How about the lash follicles? Are they affected? Do we see those little volcano signs around the base of the lash? Well, not really a little volcano sign. Look at what we have. It's the Mount Everest sign. Look at the size of the follicles. Look at this. They're absolutely huge. This is all edema coming from inflammation. Now, this is a slide you might have seen previously and looked at this and said, well, it's not blepharitis. Look, the lashes are clean. No blepharitis there. But does blepharitis mean crud in the lashes? No, it means lid inflammation. Is there lid inflammation? Heavens, yes. Look at this. It's profound lid inflammation, severe lid inflammation. It's been going on for decades. It's been going on so long, we're losing lashes. We have huge swollen follicles. Our meibomian glands are shot, and now our lacrimal glands are shot. This is probably an 80-year-old patient, maybe 90. No question. This is the patient who comes in and says, Doc, my lashes are all falling out and they're not regrowing back in. Well, no wonder they're not regrowing back in. These lashes are barely hanging on for dear life. And you might say, well, why don't we see biofilm in the lashes? The answer is easy. What does the lash have to be doing before it can pull a chunk of biofilm off? It has to be growing. These lashes are barely growing at all. They're probably all getting ready to fall out. They couldn't pull a chunk of biofilm off if their life depended on it. So you don't see collarettes many times in late stage disease because lashes aren't growing. The other reason is, at this point, the bacteria have become their own worst enemy. Everything is so dry that it's probably too dry to support very much of a thriving bacterial biofilm. So you might not have much biofilm at this point. The biofilm have really destroyed their own nice wet environment by causing dry eye disease. But at this point, it doesn't matter, the damage is done. So next time you see a patient with aqueous insufficiency, pull your slit lamp back and look at the follicles surrounding the lashes. You're going to be amazed at how many of them look just like this, from decades and decades and decades of folliculitis. Here's a sage tree. You see no tear lake back here. Look at the destruction of lash follicles from chronic 60 to 70, 80 years of folliculitis. Now you can see biofilm here in this example. Now, does this biofilm look anything like keratin that you see up here? No, this is obviously not keratin. Another low tear lake, different patient, but look, the same kind of follicles, huge, swollen follicles around the base of these lashes and a big chunk of biofilm there in this patient. Start looking for it, you'll see it. Now, if you've been listening to my lecture and you say, well, okay, I get the folliculitis part of stage 1, that's easy to understand. And sure, I can see how I could eventually access my meibomian gland stage 2, but I'm not really kind of getting this lacrimal part yet. It's so far up there. How does biofilm get up there and cause aqueous insufficiency? Maybe you're not buying that that's part of the same disease process. Well, I'm going to ask everybody in attendance here, I'm going to ask you a question here, and it'll prove to you that this is all one disease. Every day in our practices, we see patients walking in and they're complaining of burning eyes. Can't read very long. Doctor, my eyes are watery. I got a drop of tear running down my cheek. We see a lot of these patients, and you examine them and you see, well, there's a tear breakup time of maybe a second or two, if that. And so you back up and you say, well, Miss Jones, you have evaporative dry eye disease. And the patient looks at you like, weren't you listening to me, doctor? How can I have dry eye? I have tears running down my cheek. My eyes are watery. So you have to draw back and explain, well, you're missing the lipid part of your tears. So there's easy evaporation of your aqueous part, and your aqueous overcompensates. And so you end up with too many watery tears because you have no lipid part of your tear. We see it all the time. All the time. Well, let me ask you a question. Have you ever seen this scenario flipped? Have you ever seen a patient walk in and instead of having lots of aqueous and diseased meibomians, have you ever seen a patient walk in and have lots of lipids and no aqueous? Even once in your practice, have you ever seen that? You might think, well, maybe a Sjogren's disease. Okay, well, Sjogren's is an autoimmune disease. That's not an inflammatory lid margin blepharitis. We don't see that disease process. We don't see patients walking in with oil running down their cheek, healthy meibomian glands, and no aqueous, right? It can't happen. In order to get to aqueous deficiency, lacrimal involvement, you have to have already gone through meibomian gland involvement. You would have had 20 years of meibomitis, so you're not going to have healthy meibomian glands at that point. You might have some lacrimal still trying to put out aqueous, but you're not going to have meibomian lipid. That's why you never see healthy lipids in the face of aqueous insufficiency. It can't happen. It's part of the same disease process. So think about this. If aqueous insufficiency was a separate disease, as they tried to tell us, they say, oh, it's an overlapping presentation of a different disease process on the lid margin. Well, if it was a different disease, simply overlapping meibomian gland disease, wouldn't you expect to see that disease, aqueous insufficiency, show up in front of meibomian gland disease? If it's a separate disease, it should show up maybe up to 50% of the time, show up ahead of meibomian gland disease, but we don't even see it once. What does that tell us? It's part of the same disease process. You can't get aqueous insufficiency without meibomian gland diseases already being virtually destroyed. So that should really cement at home that we're not talking about multiple overlapping presentations. We're talking about one disease process with different stages. That's what's fooled us. How many diseases do we know of that last a lifetime? The only one I can think of is a biofilm that becomes blepharitis. It's essentially there our whole life. But how it looks in a 3-year-old is different than how it looks in a 20-year-old, especially a contact lens wearer. It's different than a 60, it's different than an 80-year-old. It shows up differently at each different stage of life, depending on what structure is being affected. But it's one disease process, so it's been fooling us. But now we know it's secret. Now we got it figured out. It's biofilm. And how it presents depends on what part of the lid anatomy is now being affected. And the different parts of lid anatomy are just dependent on the anatomical positions and the nature of the glands and how easy or hard they are to access. Now it's easy to understand these diseases if you understand biofilm. It all makes perfect sense. And then finally, if it goes on long enough, well, are the tendons that hold the lids in proper position, are they immune to inflammatory lid margin disease? Obviously not. They're not immune. So if it goes on for long enough, entropy and ectropion, floppy eyelid syndrome, as the entire lid becomes damaged from chronic inflammation. Now, I picked on the little 85-year-old lady who's walking in complaining of her lashes falling out when essentially her whole lids or margins are shot. Now I'm going to pick on the little 85-year-old man. This always seems to be men that this happens on. They come in, you sit down at the slit lamp, and you look at them, and you back up, you say, my goodness, Mr. Jones, tell me about your eyes, tell me about your lids, how are they bothering you, how are you treating it? What have you done for this in the past? And Mr. Jones looks at you and says, how many times do you hear this? Doc, my lids are fine. I don't have any problems. And you scratch your head and you think, my God, these are the worst lids I've ever seen. How can he say he has no symptoms? Now think about it. If follicles can be affected and eventually killed off, and meibomian glands can be affected and eventually killed off, and tendons can be affected, lacrimals can be affected, what else can be affected in this full thickness lid margin inflammation? The nerve endings. These patients actually get an inflammatory neuropathy. No wonder they can't feel anything. Now ask these patients this question. If you, next time you see somebody who says, oh no, I'm fine, no problems, and they look like this, ask them this, did they ever used to bother you? And here's what you're going to hear. If they can remember, they'll say, well, yeah, 10 years ago, they used to give me some trouble, but I got over it, doc, I'm fine now. Oh my gosh, how many times did I hear that when I was in practice? Never did understand it until now. No, Mr. Jones, you didn't get over it. You just don't feel it anymore because you fried your nerve endings. So these patients need help with the worst one in the world. Just remember, inflammation takes no prisoners. Everything is eventually affected. Now, this is not meant to show at what time things start. It's different in everyone, right? It's earlier in contact lens wearers. It's later in non-contact lens wearers. But the point is, once you get folliculitis in orange, it doesn't go away. It's still there. It doesn't stop just because meibomitis starts. And meibomitis is always there, just getting worse, even though lacrimal disease starts. But we always look at the worst thing we see on the eyelid. That's what we focus on, not realizing, hey, when you see a dry eye patient, a dry lake bed back there, look at the meibomian glands. They're going to be gone. Look at your lash follicles. They're going to be huge. And same thing goes when you finally start seeing lid destruction. All the other stages will be there if we just start looking for it. Now, what are the risk factors of DEBS? Well, obviously, age is the big one, just more years of biofilm buildup. Hormonal factors can play a role. So there can be multi-factors in whether it's better or worse. But these are not etiologies. These are factors making it better or worse. Hormonal factors, medications, contact lens wear. This is a huge, huge risk factor here. When you put a 20-year-old in a contact lens, within 5 years, excuse me, I have a little cough here, so I don't want to cough in everyone's ear, so I'll mute once in a while. When you put a contact lens patient in contact lenses within 5 years, you've given that 25-year-old the biofilm of probably a 50-year-old. Contact lenses are a biofilm accelerant. And we kind of know that. There's plenty of studies that show that there's biofilms colonizing contact lens cases. Where does that come from? The contact lens. Where does that come from? Well, the eye. That's where it comes from, the eye itself. It just didn't magically show up in a contact lens case. It originated on the eye itself. Bacteria love a safe haven of a contact lens because the contact lens has no immune system within it. It has no circulatory system. It has no white cells, so it can't fight off a biofilm in any way, shape, or form. So bacteria love that. So next time you put somebody in contact lenses, say, sure, I'll put you in a contact lens, but we now know what's going to happen. You're going to get an early, thicker biofilm with this biofilm. You're going to early, thicker biofilm with your contact lenses. So you're going to come in every 6 months. Let me check your contacts. I'll check your prescription. And while you're here, we're going to clean your lids up. And we're going to prevent you from getting an earlier, thicker biofilm, because if we don't, it's eventually going to cause dry eye, blepharitis, and contact lens intolerance. Remember that. Contact lens wear, you'll have contact lens intolerance once you get an inflammatory biofilm. And then we get some children with some virulent strains of staph that we see that occur early in life. Those are kind of the exception. Now, what's the treatment history? Well, we know the treatment history. All these things have come out now since what I had when I got out. Baby shampoo was all we recommended. Now we've got all the other things. They all fail equally because we're trying to remove a bacterial superglue. They don't work. We know that. We see that clinically, yet we still recommend it because we've got nothing else. Well, actually, now we do. So you can really stop recommending these home scrubs. They're worthless. In-office debridement was on the right track with a Q-tip, which is ineffective. Golf spud, which is barbaric, but we're on the right track. Scraping a metal blade across an inflammatory bio-laden lid causes bleeding, causes easier access for biofilm and virulence factors. Don't do this. This is barbaric. Toss your golf spuds in the trash can. LipiFlow. Now, this is an important product here, LipiFlow. It does heat and express, gets the meibomian out of the meibomian gland. That speeds up the recovery of the meibomian glands. It gets that combination of biofilms, saponified lipids, bacterial toxins. It gets it out of there. Now, not 100%, but it gets the meibomian gland where it can actually start getting rid of that stuff on its own, which is important. And nutraceutical is also important. These are sick meibomian glands, sick lacrimal glands. Treat them from within by getting patients on some of these nutraceuticals, these good omega-3 fatty acids. So now let's talk a little bit more in detail about what BlephEx does. Now, if you're going to have a dry eye clinic and you're going to claim and profess to treat dry eye disease, this is mandatory equipment. If you're not getting rid of your patient's biofilms, you're not doing diddly for their dry eye disease. BlephEx spins a little microsponge about 2,500 RPM along the lid margin, results in completely clean lids for the first time in these patients' life. Now think about that, for the first time in their life. Since they colonize their lid margins, for the first time they're biofilm free. But it's still down within the lash follicles. It's probably still down somewhat within the meibomian glands, even if you do a LipiFlow. So it's going to come out through extension and eventually colonize that lid margin again. So we need to repeat it every 4 to 6 months to keep it going. And it's a private pay procedure. Most doctors are charging $200 to $300 for a treatment. It's exfoliative, it's atraumatic, results in complete removal of biofilm from the surface, and it debulks bacteria densities now down to below QUORUM-sensing numbers. So essentially, we're turning the switch off. If you get the numbers down low enough, they're below QUORUM-sensing, so they stop producing virulence factors. We're getting about an 80 to 90% patient acceptance in that price range we mentioned. So it's important to know you cannot claim to treat dry eye without having a BlephEx to remove biofilm, because we get rid of the source of inflammation on the lid margin. We're not a medication saying we're going to suppress inflammation. Only works about half the time. It's very expensive. We're going to get rid of the source of inflammation on the lid margin. And we're going to save patients money. Have you priced Restasis recently? Or priced Xiidra, even with the copay, how much that is? We can spend less than that on a 3-time-a-year BlephEx treatment and actually get a profound result on the lid margin. So now, which eyelid is Restasis and Latisse going to work best on? Obviously, this lid with no biofilm in the way. Now adopted by all these teaching institutions. We're very proud of Johns Hopkins coming on board now, Mount Sinai School of Medicine, New York City, UC Irvine in California. They all now have BlephEx treating their dry eye blepharitis patients. We're all over the world, big in Australia, big in the UK, but we're obviously biggest in UK and Canada. And here's our US map. Little gold pins are doctors who have sat through this lecture. They become certified practices, and the green balloons, they just say, well, that makes sense. They bought it and went to work. We now have close to 2,000 doctors in the US and Canada using BlephEx. nominated for Product of the Year in the UK for our second year in a row, nominated as Product of the Year. Now I'm going to ask you guys, I can't see your hands, I'm not lecturing to an audience, but does everyone listening to me brush your teeth at least once a day? Or at least once a month? We might laugh if we hear that question. Of course we brush our teeth. If you maintain good oral hygiene, you have a pretty good chance of dying with your own teeth in your head. But how many people, if you ask an audience, how many of you all had your lids professionally cleaned every 3 or 4 months? You won't hear any chuckles. You'll see people looking at each other. No hands will go up. Look at the job dentistry has done over the past 100 to 150 years ago. No one used to brush their teeth back 100, 150 years ago. And what happened after 20 to 30 years of chronic gingivitis? Everyone back then lost their teeth. Everyone had dentures. Everyone had full sets of dentures. Don't see it much more today because dentists have done a great job educating their patient population on the importance of oral hygiene to prevent gingivitis and tooth loss. We need to catch up. We need to educate our patients on the importance of lid hygiene to prevent blepharitis and meibomian gland loss. It's an exact, direct analogy. You know, feel free to use that analogy with your patients. The patients understand oral hygiene and keeping their own teeth. They'll understand lid hygiene and keeping their own meibomian glands. And if we do that, and we make professional lid cleaning in the office as commonplace as brushing our teeth, certainly has to be as commonplace as professional dental cleaning, I truly think we can make these artificial tears go in the same dustbin of history that full sets of dentures have gone into. But we just have to get to work and start treating these lid margins, getting rid of the source of inflammation. Now here's a little video. Will, did we get our sound?
No, the sound doesn't really work on GoToMeeting. We'd have to download another application.
All right. So this is a little video. I'll just play a few seconds so you can see. This is what goes up in your waiting rooms to educate patients on the importance of lid hygiene, and it just shows a description of what's going on. This is the biofilm. These buildings up here. You got bacteria producing biofilm. Gets down to the meibomian glands, causes irritation, dry eye disease. BlephEx removes that biofilm from the lid margin and allows tear production again. And so this really helps people keep their own tear glands working and a biofilm-free lid margin. Now, that's what the education starts is in the waiting room. It continues to the exam lane when you pull out your little desktop laminated poster and you explain to patients that they've got a vicious cycle going on their lid margin. They've got bacteria producing biofilms. Biofilms produce toxins. Toxins decrease tear production. You get more bacteria, more biofilms, thicker biofilms, and this goes on and on and on. You tell them we're going to break that cycle today. Now that's an important thing to tell them. It's a vicious cycle, use that term, and we're going to break that cycle today before you leave. Otherwise, here's the third thing you tell them, it's going to progress. And that's it in a nutshell. Ms. Jones, you have a vicious cycle going on your lid margin with bacteria producing biofilm like plaque on your teeth. It's causing inflammation. It's causing you to lose your meibomian glands. Or maybe you caught it at stage 1. It's causing swelling of your lashes. You're going to end up losing your lashes and eventually lose your meibomians. Nevertheless, we're going to treat this today before you go, because if we don't, what's going to happen? It's going to progress to stage 3, where you're going to have horrible inflammation, no tears at all, and eventually you're going to get to where your lids are drooping out or drooping in. And this looks horrible. We can't let you get to stage 3, let alone stage 4. You got to treat it here. Ideally, treat it before they've lost all their meibomian glands. Remove the biofilm, remove the source of inflammation, and allow these lids to heal. And certainly the earlier you treat, the better. So those are the 3 things important to explaining this to the patient. A vicious cycle, we're going to break it today, otherwise it's going to progress. And it'll come back because the bacteria aren't going to go away, right? We're not sterilizing the lid margins. So it's going to come back. The bacteria are going to start building biofilm the second we stop doing the treatment. They're right back to, they don't care, they're right back to building again. And within 4 to 6 months, they're going to start causing damage again. So it's a repetitive treatment. Every 4 months when there's obvious disease, every 6 months in our contact lens patients to prevent disease. And isn't that the ideal here? if we can prevent this disease from ever starting, from ever taking one meibomian gland, isn't that the ideal? We've got to start doing it. We have to educate our patients. And so we provide this poster here and this poster here to help you educate those patients. Now, next time you see a patient that walks in with this meibomian gland disease, this ongoing destruction of the meibomian glands, horrible inflammation, or like this, God forbid, think about what the oral equivalent is. What does this look like if it's going on in the mouth? This is what we're letting walk out of our practices in terms of lid margin disease. We can't afford to do that any longer, because once you lose that meibomian gland and it atrophies and it scars, then we've lost it for good. Like losing the sockets of these teeth here, you've lost it for good. We can't let that happen anymore. Now, to further the education process, we also now have a lash cam. And I'm going to let Will take over here just for a second, and he'll take over my screen and talk to you a little bit about how the lash cam works and educates the patient as to how their eyelashes look in real time. Will, you want to go over your little presentation real quick?
Yeah, thank you, Dr. Reinerson. The lash cam is a 20, 40, and 80 times magnification Wi-Fi enabled microscopic camera, which helps you educate the patient about the condition of their eyelids and inflammatory lid disease. But most importantly, it does this in real time. The lash cam streams the image right to the lash cam app, which is then on your smartphone or your tablet through a Wi-Fi signal. But we'll talk more about that later. The lash cam is really compact and it's easy to use. Uses a rechargeable battery. There are a couple of buttons on the camera itself. There's two wheels, one on and off wheel, and there's you can use that to dim the light, as well as a focusing wheel, which is used to manually focus the camera for crystal clear images. Couple of buttons. The magnification button toggles through the 20 times, 40 times, and 80 times setting, and then there's a button on there as well that you can snap photos, which are then sent directly to your device's camera roll. And then the little eyepiece on the end, you can take that off and wipe it with an alcohol swab in between your patients anytime you use it. But most importantly, the lash cam is a patient education tool. We've got to educate our patients on biofilm because they have either never heard of it or do not think they have one. Once we show them the biofilm on their lid margin with the lash cam, they will understand that it needs to be removed. So in turn, it'll help you close more BlephEx procedures in your practice. You might be thinking, but is it only used for viewing the patient's biofilm? And of course it's not. The lash cam can be used for viewing corneal scars, DLK, foreign bodies, anterior cataracts, iris nevus, and many more. And it also is billable as anterior segment photography. We found huge success taking before and after photos with the lash cam, and the beauty of it is that it can all be done in less than 10 minutes. You just snap a before pic, treat with BlephEx, and then snap the after. And you can show your patients a biofilm-free lid for the first time in their life. And it only took about 10 minutes. Sometimes you may even catch a glimpse of one of these nice little mites here living down in the lash follicles. And yes, we have been able to diagnose Demodex with the lash cam. Here you can see a nice before picture that Dr. Reinerson took of another doctor at a trade show last year. Check out all of this biofilm built up around his follicles. It's everywhere. So Dr. Reinerson, of course, did the right thing and cleaned this doc's lids up. And here's the after. Clean lid for the first time in 50 or 60 years. And see him yet? This little guy right here. We can see his tail popping out of the follicle right there. So not only were we able to remove his 60-year-old biofilm, we also were able to diagnose him with Demodex and treat him accordingly. And then lastly, before I give it back to Dr. Reinerson, I'll just run over how quick and easy the process of using the lash cam is. First things first, you just download the app. It's free. It's called the Lash Cam app, either from the Apple Store or the Google Play Store. And once you've downloaded the application, you just turn on the lash cam by rolling the on and off wheel all the way up so the light turns on. and then wait 30 seconds for the green light on the base right next to the charging port to start flashing. Once it's flashing, head over to your Wi-Fi settings of your smartphone or tablet, connect to the Wi-Fi signal that starts with lash. Once you get all checked off as connected, you are ready to open the mobile application. And as soon as you open the app, you should see a live image of what the camera is seeing. From there, you just have to place the cam right against the eye and focus on the lid margin. And this will take a little bit of practice at first, but you will quickly become a lash cam pro. Once you have your image focused and at whatever magnification you like, simply snap a photo using the button on the lash cam itself. And if you have your device's volume turned all the way up, you'll hear a little shutter sound indicating that the image was taken. Then it's as easy as opening up your camera roll and reviewing the images with your patient. And you can email those images to yourself, use them in your larger computer system, attach them to patients' files. And that pretty much is it. I hope you enjoyed the brief presentation over the lash cam, and I will hand it back over to Dr. Reinerson.
Okay. All right, just one point of correction here. When Will mentioned the 10 minutes, that's including the BlephEx procedure. So you can show them a picture before, do a BlephEx, and show them a picture after. But just to show them their lids sitting there in the chair, I mean, it literally takes probably less than a minute to get the lash cam fired up and start showing them pictures just like this of their lid in real time. So they're looking at the device with one eye while you have the lash cam on the other eye showing what that lid looks like. And once they see their lids at 60 to 80 mag, seeing is believing. They'll always say, oh my gosh, that's gross. Oh, that's disgusting. Oh, yeah, I get it now. Please clean that up. So it really helps stress the point of lid margin hygiene. Now, how do we be successful with our BlephExes in our office? Well, again, we got to educate the patient about consequences of not getting their lids clean. It's like teeth falling out if we don't maintain good oral hygiene. So educate your patients. You have to be assertive. You can't just give out a brochure. If you're just a doctor who says, oh, we've got this, do you want to do it, or let me know, you'll never do a single BlephEx procedure. I recommend not giving out brochures ahead of time. Give them out after a BlephEx procedure. But if you think that you're going to give out a brochure and it's going to close the patient to get this done, it's not going to work. You have to explain to the patient, be assertive, be willing to sell, and they have to sense from you that you truly believe in the importance of what you're telling them. If they sense any hesitation in your voice at all, if you're uncomfortable selling something, you're going to have a harder time getting patients to accept this. But if you're assertive and you say, look, we didn't know this before, we know it now, we have to start removing biofilms. And here, let me take this lash cam, I'll show you what I'm talking about. This biofilm is going to end up killing off your tear glands. Use all the information we give you, all the materials we give you in your starter kit to educate the patient. And if they balk at the cost, well, compare to the cost of drugs. Say, okay, I can put you on Restasis, but it burns and stings and it doesn't work all the time. And here's how much it's going to cost on a monthly basis. You can also do this, treat one eye for free if a patient still balks at paying $200 to $300 for a treatment. Do one eye for free, let them feel the difference. And say, now I'm going to come back, have you come back in 2 weeks, and we're going to check your eyes, make sure it's doing better, and then you tell me in 2 weeks if you want the other eye done. And 4 out of 5 times they'll say, okay, I get it now, please do the other eye, and then they pay for the full price for the procedure. And make sure you involve your staff. If any of your staff members have Blepharitis, dry eye, if they have DEBS, get them treated so they could talk about, look, I got treated, I've never felt as good in my lids. Sometimes people can have symptoms and sort of not know it. They kind of get used to it and thinking, well, I'm just getting older, that's how my eyes feel now. Until you clean their biofilm off and they'll go, wow, what a difference. My eyes feel fresher, cleaner, lighter. I blink easier, it's smoother. And they didn't even know they're having problems because it comes on so slow for so long, they think it's normal until you clean them up. The difference is remarkable. You're going to be amazed at the outcome of your patients once you start cleaning their lids. Does it really work? Well, here's the first study that came out looking at the clinical effectiveness of lid debridement with BlephEx. And just to cut to the chase, this is the important number. Tear breakup time increased by 60% after just one treatment, measured 4 weeks later. 60%. I mean, think about that. That's a huge increase after just one treatment. Here's another study that came out. Now think about this. This study looked at contact lens wearers, symptomatic contact lens wearers. After just one treatment, 59% of those patients were converted from symptomatic to asymptomatic. Contact lens wearers who are getting ready to drop out of their contact lenses, that's not good for the patient, that's not good for the doctor, it's not good for anybody, were converted, 59%. Now, if they had continued this study and taken that 41% that didn't convert and treated them again in a month or two, they would have gotten even more converting. Here's another study that came out by Dr. Alice Petropoulos, a 66% increase in tear breakup time after just one treatment measured 4 weeks later. Now think of what these tear breakup times are going to be like, not after just one treatment, after the second, after the third. Think of what these tear breakup times are going to be like after, say, 3 years later, if a patient's been getting it done every 4 months. They're going to be normal, folks. If they have any meibomian glands that are capable of being resuscitated, they're going to have normal tear breakup times. We can convert these lids to normal and then keep them there with continued treatments. Think about our contact lens patients who are so upset that day we say, well, you just can't be in contacts anymore. You're now contact lens intolerant. Sorry. We can keep them in their contacts. As soon as that patient comes in, having any symptoms at all, they need to go on a regular BlephEx regime. In fact, in a perfect world, they need to be told about getting a BlephEx done every time they come in from a contact lens, every time they come in for a contact lens check, from the moment they go in contacts. And they'll never get into dry eye or contact lens intolerance. They'll maintain a healthy lid margin surface. These are important services we can now offer our patients and make a huge difference in our practice. Did you ever think you'd have a treatment for contact lens intolerance other than discontinuing contacts? No, I never did. Did you think you'd ever have a treatment where you could actually take a tear breakup time of 6 and now make it a 10? Did we ever think we'd have something where we could do that? Now we do. If you don't have a BlephEx in your practice, you are shortchanging yourself and you're shortchanging your patients. Now, who are we looking for? I mean, are these patients, are they already walking in our practice? Yes, every single day. Every elderly patient with blepharitis or dry eye, they have more years of biofilm and exotoxin accumulation. Of course they need treatment. There's tons of these patients walking in your practices. How about contact lens wearers? We see them every day. They need it every 6 months or every 4 months if they're already getting disease. Every pre-op cataract and pre-op LASIK patient needs to have this done to reduce the incidence of infection. Remember the study that showed the 32 out of 34 bacteria surviving the surgical scrub were biofilm formers? So we can have a marked reduction in incidence of endophthalmitis by just cleaning these patients' lids up before cataract surgery. If you're the surgeon, you should insist on clean lids before you do surgery. If you're the referring physician, then you should be cleaning them up before you send them to your surgeon. Reduce the chance of getting the worst thing that can happen, the endophthalmitis. And tell your patients, look, we have this procedure we can do. $250 is the cheapest insurance in the world against the worst thing that can happen. I so strongly recommend it that I just can't refer you out until we do it. We've got to get your lids clean because I don't want to see you coming back here as one of those rare patients with an intraocular infection. We could lose the eye if that happens. So let's get this done first. It needs to be done anyway because you have biofilm, you have this inflammation starting in your lid margin. So let's get it done before your surgery, and then we'll need to continue to do it. And then anytime you're going to think about putting a patient on Latisse or Restasis, give those drops a chance to work. Get the biofilm off first, and you're going to get amazing results from these drugs right here. Amazing results. You'll still see a strong need for Restasis. And that bad patient with that horrible, the lashes falling out, no tear lake and all that, this horrible red inflammation, get those patients on Restasis or Xiidra, and you're going to see a great response to these drugs. And you can jumpstart that reduction in inflammation, which starts the healing process in those patients. So better medicine, it's better money, and it's happier patients. Now think about this. For every 10 patients you do per week, every 10 patients, not 10 a day, 10 a day is doable, but let's just say you do 10 a week. you're adding $100,000 in revenue to your bottom line. That's good for you, that's good for your practice, that's good for your employees, that's job security, that's bonuses. Just 10 a week. Everybody can do that. Our #1 BlephEx practice in the country, they're doing about 60 a week. That's an extra $600,000 in cash, check, or credit card added to their bottom line, and that's 60 patients per week who are now sending in other patients saying, finally, I found a doctor that took this disease seriously and did something about it. My eyes have never felt better. These are patients that every practice has. These are patients that you guys have in your practices that are currently walking out the door if you don't have BlephEx to offer this lid changing procedure, this tier changing procedure, and adding this revenue to your bottom line. There's no reason not to have a BlephEx. Now the BlephEx starter kit sells for $4,995, and it includes everything you see here. And this is a great value. The BlephEx handpiece and the charging base includes this hand-painted eyelid model so you can describe what's going on to the patient. It includes the DEBS model. These two little lid scrubs, if you think they have DEBS, you use this one, or this is just for maintenance. It includes these posters for education. It includes our Collins lid expressor for manual forceps expression of the meibomian glands if you want to do it in heat and express in the office. Little animation video, this treatment headset that has these different magnification lenses and also illuminates so you can do a great job seeing up close and cleaning. And it also includes, which I don't have on here yet, is the lash cam is included. Everything is included for less than $5,000. Now getting a BlephEx is no risk. What's risky is not getting a BlephEx. And here's why it's risky. Revenue keeps walking at your door as it's done over the past year. You put your patients' meibomian and lacrimal glands at risk of getting damaged, and you risk losing your patients to one of the many practices that's currently offering BlephEx to their DEBS patients. So not having BlephEx is risky. Getting a BlephEx is zero risk, and here's how we make it zero risk. Upfront cost low, I said less than $5,000 for at least a $100,000 revenue stream, and we guarantee everybody listening today, you'll make $100,000 your first year guaranteed, or we'll buy BlephEx back from you. That's how sold we are on the ability of our doctors to make great revenue and take great care of their patients with BlephEx. It's guaranteed. Pace yourself with just 25 patients. 25 patients. How long will it take you to see 25 patients with lid margin disease? Depending on the size of your practice, probably 2 or 3 days. Your per patient cost is only $35. So even if you decide to do one for free to show a patient what it feels like, you're at $35. 60-day money back guarantee. So if you don't like it, you don't think it works, you don't like it in 60 days, you're not getting a minute to do it, send it back. But I promise you, you'll have it paid for in 30 days. You win and your patients win. Now, we feel so strongly about this, and it seems like we're pushing this hard, but look, this is important stuff. We can finally put an end to this lid margin disease. And if you want to copy my slide deck to educate a group of docs or educate your employees or just re-educate yourself, send a request for it to this is my personal email right here, and let me know whether you want a version for Mac or PC, and I'll be happy to share my slide deck with you. This is something that everybody needs to know. There's no secrets here. So get yourself a new BlephEx system and also take away a new understanding of this disease process. You can do something about Blepharitis and dry eye disease. If you claim to be a doctor and you're going to treat the disease, the only product out there that's going to remove biofilm thoroughly from the lid margins is a BlephEx. So you're a doctor. Change the way you treat this disease and get your BlephEx system. It's going to be as integral in modern eye practices as having a slit lamp. And you also get a lash cam with it. So thank you for your attention. DEBS thanks you. My little DEBS here, waiting for me to finish up. He thanks you as well. Thank you guys very much. We're open for questions now. If anybody would like to shoot some questions via the chat.